name is Frank Vicini. I'm a radiation oncologist. My expertise is in breast cancer treatment. Depend a lot upon the primary tumor. That is, whether or not it was from the metastases are from the breast, the prostate, the lung, whether they originate in the central nervous system themselves. And of course, to a radiation oncologist, it depends upon whether or not there's a single lesion, there are multiple lesions, or the diffuse lesions. The best way to look at it is to take it in each of those various ways. In other words, let's start with multiple metastases. That is from 5 to 10 or more metastases to the brain. The typical treatment consists of whole brain irradiation given in 10 to 14 fractions, that is treatments per day. The doses needed to control metastatic disease to the brain with reduced side effects have been worked out through various studies through the NCI. In other words, studies have looked at what is the dose that gives the greatest durability, the least amount of side effects, and of course, whether or not these patients need to be retreated. For whole brain radiation for metastases, typically there's an 80 to 90% response and control rate, with very few of those patients needing retreatment. The techniques are currently today are investigating whether or not we can block certain structures to prevent some impairment of memory loss, or even to give concurrent medications to reduce the impairment of memory loss, which can occur to some patients with whole brain irradiation. The second area that we use to treat brain metastases is for isolated brain metastases. That is 1, 2, or 3 metastases. In that setting, we typically use stereotactic radiation therapy. And typically, you give 1 to 5 fractions of radiation therapy in that setting. Because the radiation is targeted so precisely, the doses to the normal areas of the brain are reduced dramatically, and you can give a ablative dose to a particular site in the brain, whether that be 1, 2, or 3 metastases, while keeping the toxicity to the rest of the brain at a minimum. Again, less normal tissue effects, less potential hair loss, fatigue, memory impairment, etc. And there's been a lot of data accumulated over the past 10, 20 years that shows the treatment of isolated brain metastases with radiation therapy, there is a potential for improvement in survival. So not only for palliation of brain metastases, but also for improvement in survival. There's various ways to deliver radiation for isolated brain metastases, You can use stereotactic radiation therapy that's LINAC-based. That is your typical linear accelerator that is used to treat other disease sites or just the primary site with breast. Or you can use more sophisticated equipment such as the gamma knife, which is developed particularly to treat isolated brain metastases through a series of over 200 beams focused on one central site. Again, the whole concept being treating the target with minimal doses to adjacent structures, requiring improved imaging, improved targeting, immobilization, and certainly online imaging to verify each fraction that you're giving.